Bowling Green State University. He's going to give his presentation and a brief history of his background.
All right, there. Thank you. Thanks for coming out on Sunday morning. This is the elite of South Texas, right? The ones who are dedicated. So I appreciate you coming out. If you didn't mind, just forego all the bloviating about the titles and the awards and the honors, and let's just talk about ankles. I'm Matt. I'm an athletic trainer. So I want to talk about ankle impingement syndrome and exactly what that is. If you're like me, I've always been mystified by the number of athletes who come to me with chronic ankle pain and what that entails, and this hurts and that hurts, and you go to do the evaluations and they don't seem to have anything glaring that stands out in an evaluation as terms of an etiology, a cause, a mechanism. It's just my ankles feel weak, my ankles feel sore, it hurts when I point my toe or whatever. And this has kind of been fascinating to me over the years, so I begin to investigate what could that be, and it turns out there's a syndrome. And the syndrome is ankle impingement syndrome that kind of identifies maybe a lot of that. So my goals for us this morning is just to go through kind of what ankle impingement syndrome is, the causes of it, some of the physical examination that we would do to rule certain things out in terms of a differential diagnosis, and then some treatment interventions for that. So if you don't mind, we'll just jump right in. A definition of ankle impingement syndrome is defined as a painful mechanical limitation of full ankle range of motion, and here's the key point here, is secondary to osseous or soft tissue abnormality. So far, it's one of the big things with ankle impingement syndrome is, again, it's painful limitation. So basically, they can't move their ankle the way they want to. Now, there's always a range of motion associated with it. So it's not like they're totally immobile. They can move it. It's just at certain points in the range of motion, they'll say it hurts when I go here, or hurts when I do this, hurts when I dorsiflex, plantar flex, invert, evert at this certain point. Not through the whole range, but just at a certain point. And typically, it's secondary, or it happens as a result of some other injury that occurred some other time. And most, as all of you know, many of our athletes have sprained their ankle, and all of a sudden they have this pain. So that's our technical textbook definition from the research. A secondary description that you also find in the literature is a painful restriction of motion at the tibio-talar joint due to entrapment of swelling or soft tissue, torn ligaments, or osteophytes, which are bone spurs. So it's usually associated with some previous ankle injury that really never healed all the way. And that's kind of what we're talking about here. So just so you know, there are two types of ankle impingement syndrome, anterior and posterior. And you can see there kind of the hot spots on the ankle and foot there. So the posterior is between the tibia and talus, and it usually is a consequence of plantar flexion, so extreme plantar flexion, and they get that little impingement in the back there. And then anterior is the more common of the two, by the way, and that is right at the instep, right in the front here, in the front of the ankle, and that usually happens when you dorsiflex your ankle, or extreme dorsiflexion. So there are some examples here of extreme dorsiflexion that are real common, and we see these types of injuries in these types of athletes. So I just have a few pictures here of extreme dorsiflexion, because a lot of us think like, well, my athletes don't do extreme dorsiflexion, or they don't do extreme plantar flexion, and really they probably do way more than we realize. So here's a few examples just of training. All of our athletes, or many of our athletes, are weightlifting, doing box jumps, plyos, bounding types of activities, toe raises, things like these. These are all examples of extreme dorsiflexion. And I'm looking at the soccer player there is the plant foot is the one that's in extreme dorsiflexion. So those are some examples of extreme dorsiflexion that just are day-to-day activities that we kind of take for granted. And these are the things that they complain about. For plantar flexion, it's the most common is ballet and dancers. Obviously, you can see there that's some extreme dorsiflexion, and then also the weight of the athlete down on that toe and ankle as well contributes to that. We've got kicking the soccer ball on this side. And here we've got extreme dorsiflexion and plantar flexion because he's going to come down with his plant foot. That's going to impact the injury, as well as striking the ball with the instep of the foot also adds trauma to that. So that is, by the way, the most common athlete who experiences either of these ankle impingement syndromes are soccer players. In fact, I'll show you in a moment, the very first time it was identified in the literature in 1949, it was actually called footballer's ankle. So this is another thing about this particular injury or ankle impingement syndrome. It's really unique to athletes. Now, it's not that other people don't get it, but the other people that get it who aren't athletes are usually very active on top of it. So it's really unique to the highly active individual. You don't really see it a lot in the general population. And then, of course, we've got our punters and our kickers have a high incidence of this as well because of the extreme plantar flexion. So, and then if you use starting blocks as a track and field runner, also you can see her push-off foot there, and then also her front foot would also be considered extreme dorsiflexion, but particularly here the plantar flexion. So a lot of our athletes are experiencing these extreme ranges of motion. And the kicker here, the important aspect of the extreme ends of these range of motion is there's some sort of force applied to it. So as you're pushing off the block, as you're striking the football, as the dancer's on her toe and body weight and ground reaction forces are compressing the joint. So there's usually the extreme motion and some sort of axial or compressive load as well. And that's what tends to generate these types of conditions or syndrome. So here is kind of just an MRI of the anterior. You can see there on the posterior side where the arrow is at, that is what a normal joint space should look like on an MRI. And then on the anterior portion where the little star is at is where the impingement syndrome is. Now this arthrogram is actually showing a high ankle sprain. And the number one of the number one, I shouldn't say one of the number ones, there would only be one number one, but one of the major contributors to anterior ankle impingement syndrome is high ankle sprains. And we'll talk about that in a moment. And this is what's happening here. This athlete had a high ankle sprain. The synovium and the anterior portion just got inflamed and swollen, and every time they would dorsiflex, she would get impinged in the anterior portion of her ankle, and she would always complain, I can't lift my foot all the way up. It just kind of hurts. She can get it up there, but it just kind of hurts, and it kind of has a soft infeel. And it was inhibiting her performance. So a little bit of background here, as I just alluded to a minute ago. Ankle impingement has long been recognized as a cause of pain in athletes, and originally described in the 1950s as an impingement syndrome, and it's actually been considered a significant cause of chronic ankle pain. So most of our athletes, when they come and complain about that ankle instability, that chronic ankle pain, that soreness in their ankle after running, during activity, one of the things we may want to be thinking is ankle instability or impingement syndrome. 1949, again, Dr. McMurray, he's a European physician, called it footballer's ankle for the very first time. And then later on, a year later, they changed it to impingement exostosis, just to include other populations. But it originally came to be as footballer's ankle. So, get that. More background. So again, it was always considered up until recently. And recently, 2015, we started considering it something we could diagnose through clinical evaluation. But typically, it was always considered a diagnosis of exclusion, which means, well, if it's not this, it's not this, it's not this, it's not this, then all that's left is this chronic ankle instability. And because of that, it was being misdiagnosed a lot or missed completely. We would just say, well, it's not this, it's not this, it's not this, you're fine. Just walk it off. It's these other things. And then if they continue to have pain in their ankle, then we say, all right, well, then maybe there's something else, and they would call it ankle impingement syndrome, kind of as a generic name to appease the patient. But what they have found out, especially with the radiographic studies of the last couple years, is it actually does coexist with other ankle dysfunctions, and it is a diagnosable standalone condition or syndrome. So again, it's very common in active people and athletes, most likely because of the subclinical injury as an important factor in the development. Again, all those repetitive stresses and the sprains that athletes just work through and walk off. I mean, we all know So many of our athletes have ankle injuries, ankle sprains, ankle conditions that we just tape for them, support for them, brace for them, and they go back and they have relatively minor disruptions to their performance, so we just kind of let it go. And it's exactly that causes this ankle impingement syndrome later on down the road. The onset of symptoms is variable, and here's the tricky part about this. This is what I consider to be one of the most unique aspects of this injury, and that's that it is both insidious and traumatic. So an athlete can come to you with no mechanism at all and kind of having that insidious slow onset from striking the ball for 1,000 times for the last 2 or 3 years, and they really don't have a mechanism, or it can be directly post-secondary, a traumatic injury. So you've got both issues here to contend with, which is a different kind of injury to have to diagnose and recognize. So as far as anterior ankle impingement syndrome, it most commonly occurs in soccer players or athletes who strike a ball. So you would throw punters and kickers on American football in with that. And then you also have, on the posterior side, you have two very common conditions, and that would be dancers, specifically classical ballet dancers, which is, as you know, one of our emerging industries right now, emerging professions. In fact, 61% of all surgical candidates are, in fact, classical ballet dancers. So you get a lot of that. And then also fast bowlers, which is cricket, which is very similar to our pitcher in baseball. And you can even see there how, through the pitching motion, they drag their foot off the mound like that. So it's very common there as well. And does anybody ever work with a cricket team? I spent some time over in Africa for a while, and we got to do some stuff with cricket. But you don't see too many cricket athletes around here, these parts. But again, it's very similar to baseball pitchers and those who are throwing long distances, center fielders, for example. So let's talk a little bit epidemiology, a little etiology, some background here in terms of what's going on. So after an ankle sprain, 20 to 40% of patients have chronic ankle pain. Okay? Of these patients, approximately 1/3 has pain related to impingement syndrome. What that means for us is between 7 and 13 of every 100 ankles you see has ankle impingement syndrome. So that's a decent amount. That's going to mean that somebody in your high school, somebody at your university, if you have 100 athletes or more, a good handful of them are going to have this. And it's missed a lot, again, because of the other things that are around the other anatomical structures there. And then the European studies say that 3% of all ankle injuries in total have an impingement component to it. So that's maybe more than we think, and something we need to consider. AIS is thought to develop subsequent to relatively minor injuries. This is the other thing that kind of sets it apart, is we don't spend a lot of time and effort, at least I don't. I shouldn't say we. I don't want to group you in there. Maybe you're not as negligent as me, but I don't spend a lot of time with relatively minor injuries. And maybe that's some of the things we need to really begin to think about. So again, it's usually consisting of forced ankle plantar flexion and supination. And then the mechanism of injury generates a tensile force which tears the anterior lateral capsule without a mechanically significant or clinically significant mechanical instability without that. So that's the other really important factor there. Again, relatively minor injuries. But again, when we let these relatively minor injuries go untreated, we typically have these long-term impingement problems. So subsequent functional instability associated with microtrauma can lead to this synovial scarring and thickening. And that's exactly what that MRI was I showed you a moment ago. It's synovial thickening, and that's what's happening. All the repeated trauma, and again, the number one trauma for anterior is striking the ball. So they strike the ball, they strike the ball, they strike the ball, however many hundreds of thousands of times in a season, in a career, and all of that little microtrauma, again, none of it's clinically significant, but over time, that synovial lining, especially in the anterior portion between the talus and the tibia there, the synovial lining begins to thicken. And that thickening again gets trapped underneath the talus, or between the talus and the tibia when they dorsiflex, and causes them that pain and instability. It can exist on its own or with a combination of other injuries. Particularly, we blame tendon injuries, The most common misdiagnosis for posterior ankle impingement syndrome is Achilles tendonitis. We blame it, or retrocalcaneal bursitis. Those are the two most commonly diagnosed injuries that are misdiagnoses when really they have a posterior ankle impingement syndrome. And then we also see, I can't see these screens here, and then the clinical evaluation combined with imaging, preferably an MRI, is key to identifying the coexistent pathologies that might be present, which again contribute significantly to treatment failure, because this is one of those types of injuries that you can't just treat it like the other injuries, like we do sometimes. Well, is it this injury or that injury? Well, it doesn't matter. We're still going to do this prescribed course of action. So we do these particular treatments, and it doesn't really matter if it was this or that, because our treatment covers that. This doesn't work with ankle impingement syndrome. If we treat it for tendonitis, it's not going to be effective for what needs to happen, and I'll go over what those treatments are in a minute. So another interesting point here is studies of asymptomatic professional athletes. And this is what, again, is really interesting, because, again, it goes back to this minor injury idea. These are asymptomatic professional athletes. So they're not complaining of anything. They don't have any signs and symptoms. They're compensating for it in a certain way. But we found that almost 60% have some sort of impingement syndrome or bone spur in that space, which is another big contributing factor to the impingement, is a bone spur. However, it is believed that although these bony abnormalities are present, they aren't enough to cause the athlete to stop performing the way that they normally would. So again, 60% of professional athletes, again, now they've got significantly more time kicking the ball, dancing, whatever it might be. These professional athletes are referring to here, by the way, are soccer players. So they have significantly more time kicking the ball than maybe your high school sophomore or junior, and they have it. They have it, and they're just not aware of it. And that is, again, another very interesting phenomenon. How can you have this and not be aware of it? Well, it's because they learn to compensate in other ways. So range of motion studies. When you look at different studies, and they looked at MRI studies and compared the ranges of motion, and they demonstrate that the presence of a posterior bony anomaly, which is a bone spur, does not restrict calcaneal tibial angle and plantar flexion, but that full range plantar flexion can be obtained in different patterns. So that's what's happening. The athlete compensates. They have different joints that have accommodated to the fact that they can't fully plantar flex or dorsiflex. In this case, the study was about plantar flexion. But it shows here in this study what the athlete does. So when you're diagnosing this with the patient and doing a gait analysis, you need to kind of look at, well, what are they doing, these other things? Do they have subtalar plantar flexion? Is that increased? Talocrural inversion, is that increased? External and internal rotation of the subtalar joint. Typically, they compensate for this at the subtalar joint. If you look at that little list there, you'll see they're going to end up having excessive or hypermobile subtalar joint, which is usually how our athletes compensate who have this. So if they're not getting full plantar flexion in particular at the talocrural joint, they're going to get it. They're going to make up for it with the subtalar joint. And then having a hypermobile subtalar joint contributes to other problems with the foot that need to be taken care of, especially with those athletes who are running a lot. So again, these kinematic changes relate to positional changes and restriction within the joint, and particularly long term. We really don't see problems with these athletes until they're around 35-ish. And when they get to be about 35-ish is when they really show up in the physician's office, when they show up at the clinic saying, hey, my foot's not bothering me, and there's some talk. Again, now I'm speculating at this point. There's no literature on this. But you will see, I'll reference here in a minute, one of the predisposing factors for this is misdiagnosis early on and poor rehabilitation protocols early on. There is, again, some rumblings that it's possible that 35-year-old athlete can come back and claim negligence later on when hey, I sprained my ankle when I was 16 and my high school athletic trainer just taped it up and sent me out, and now it's because it's a diagnosis subsequent to previous injury. There's a, again, possibility people could say, hey, you didn't do this right, and they might come back in some way in that way. So we need one reason to maybe think about this more than we typically would. Contributing or predisposing factors. So here's kind of what we're looking at. Repetitive impaction to the anterior chondral margin, which is the instep, okay, which is right where you tie your shoes. Okay, that's the instep, and that's typically that repetitive impaction injury, again, kicking a ball in particular. Frequent or traumatic inversion ankle sprains. People who, and again, it's frequent or traumatic, so they can have just one bad one or a whole bunch of tiny little ones. And again, that builds up that thickening of the synovial lining. Os trigonum, and that is basically an extended bony spur off the talus and the posterior portion of the ankle. And a lot of people have this, but it's usually non-problematic unless it breaks off. And when it breaks off, it's called os trigonum, and about 13% of all population has this. So it's, again, you have some athletes who have this. They just don't know it yet. Ankle hypermobility is a predisposing factor, and high ankle sprain, which I mentioned a moment ago, and I'll actually show you some slides on that in a minute. So athletes who have suffered a high ankle sprain, typically this is a complication that happens down the road. Stedia process, which is that os trigonum that hasn't broken off. Okay? And then pes cavus, so high arches. Athletes with high arches are predisposed to this. Okay? And then posterior ankle impingement often occurs due to inadequate rehabilitation following an acute injury. Now, the inadequate rehabilitation is specific to misdiagnosis. That's what that means there. So I want to spend a minute on that bottom point because that's huge for what we do. Basically, it's the posterior one that's misdiagnosed like this because, again, as I mentioned, the posterior ankle, when somebody shows up with pain, right where that would be, right at the retrocalcaneal bursa, right where the Achilles tendon inserts in the calcaneus, we typically will diagnose that as retrocalcaneal bursitis or Achilles tendonitis. And we treat it as such when, in fact, it is posterior ankle impingement syndrome. It is much more difficult to diagnose posterior because the bone spurs in the posterior talus are very deep. You can't really palpate it. You can't really put enough pressure there to elicit the pain and the response that you're looking for to find the point tenderness because of the bursa, because of the tendons, because of the other physiological and anatomical structures that are there. As opposed to the anterior ankle, it's very easy to palpate and find. You can actually even feel the thickening of the synovial lining. If you're good at your palpations, you can feel the bone spur, and it's much easier to clinically diagnose. So what happens is people with posterior injuries, we treat it as something else, and we don't really address the real problem, and then several years later they show up, and I've got this thing, and it was mistreated or misdiagnosed, or the rehab was inappropriate. So here's what you're looking at here. Os trigonum and Stedia process. The one is, you can see on the far side there, it's still attached to the talus, the bony prominence there, and then os trigonum is when it breaks off. By the way, if an athlete is going to get os trigonum, it's going to happen between the ages of 7 and 13. So this is our junior high-ish, athlete around that time. And typically, when it does break off, it's really not problematic because it's actually pretty small. It's only if it breaks off and then they accumulate, and they're a dancer, for example, and they're just constantly aggravating that. So they're running. I mean, I don't know too many junior high and even early high school kids who are really into using starting blocks, for example, in track and field. I mean, my son runs track. He's a freshman, and they don't use starting blocks until sophomore year or whatever. So, but sometimes these athletes are using starting blocks in these young ages, and they just go rep after rep after rep after rep, and that pushing off and that extended plantar flexion is what does it, and it becomes problematic. So that's kind of what we're looking at there. So again, 13 to 14% of the population have this. Exacerbating factors, so things that contribute to this. So not only just the kicking and all that, but here's repetitive dorsiflexion, climbing stairs, uphill running is a big one for anterior impingement syndrome. Ascending ladders, up and down ladders. I mean, if you think about it, they use the front of their toe and they're going up and down ladders all day long. Deep squatting is a big one. One of the things that we will work with our athletes if we suspect this, and again, it's not every athlete is having this, but you can eliminate a lot of the activities or modify some of the activities, and it helps quite a bit. And then instep trauma. Instep trauma would be kicking a ball 100 times a day. Okay, and then intensifying the posterior, extreme plantar flexion, repetitive push-offs, downhill running, descending stairs, and then I've got cracked up with the literature reports wearing high heel shoes. So again, that is some of the things we want to begin to modify. So you can look at these things here, and this is a great list of if you suspect an athlete might have an ankle impingement syndrome, either posterior or anterior. This is a list you can start with right off the bat to modify some of their activities and to maybe even help you identify what might be contributing to some of their pain and chronic complaints. So let's talk about posterior for a minute, then we'll talk about anterior for a minute. And here's other names for this condition: ankle impingement, posterior impingement of the ankle, talar compression syndrome, and os trigonum syndrome. And I give you that in case you wanted to look at the literature yourself and see, what is available out there. Those are some other names you can look for. And then again, the point that I would like to highlight, and I have already starting to beat this horse, but it really is misdiagnosed as Achilles tendonitis or peroneal tendonitis. So we want to make sure that we are assessing those things. And one of the things that I'll show you when we go through the physical examination, you need to spend some good time at actually discerning and trying to discriminate between these types of tendonitis, because we don't want to just casually call it Achilles tendonitis or peroneal tendonitis when it might be a bone spur or some other impingement. So clinical presentation, this is what your athlete will typically complain of with posterior. They'll present with limited plantar flexion, and they'll have focal tenderness at the retrocalcaneal region. And you'll also be able to feel the inflammation there. And that, again, is what leads to that misdiagnosis of tendonitis, Achilles or retrocalcaneal bursitis, because you can see it. It's point tender, it's swollen, and it's just easy. This is an easy one, we say, or I've said. This is an easy one, retrocalcaneal bursitis, and let's just move forward, when really it's not at all. So they'll have pain in the Achilles or retrocalcaneal region, often precipitated when plantar flex, which means it gets worse when they plantar flex. So when they're in a normal position, you ask them to plantar flex, and they have the increase in pain. They have a history or impact of axial loading during plantar flexion. Okay, so this is another important. So you want to go back, and there's where your history, knowing the athletes, how they prepare, how they train, how they practice, what sport they're in, can help. And then location of the pain is quite discrete. Okay, it's very focal, it's very specific, and it's associated with posterior thickness and swelling. So again, you can see those. Now, all of those things, how they present, again, is very the same as Achilles tendonitis or retrocalcaneal bursitis. So you want to make sure you add posterior ankle impingement syndrome to your list when you've got pain back there, and make sure you rule out for that. So here's what you're looking at on an X-ray. You can see here is that os trigonum that kind of broke off, and again over the repeated, and you can see how it gets pinched. They also call it the nutcracker syndrome. By the way, I didn't put that on there, but you can see why they would call it that as well. And it gets impinged in there, and then again over the years, that little broken off osseous fragment will begin to ossify, it'll morph, it will change, it alters the kinetics and kinematics of the ankle, and it just becomes, as you can imagine, extremely problematic. And it's relatively simple surgical procedure just to go and remove that. But that's what you're looking at in an X-ray. That's typically what it looks like. And again, most of the time it's osseous, but it's also can be thickening, hypertrophic thickening of the structures in the posterior or anterior ankle. So clinical presentation for anterior, and again, you need to remember they're going to present with limited ankle dorsiflexion and supination. They're going to have a very specific focal anterior medial tenderness and swelling, and again, aggravated by dorsiflexion. So pain, anterior medial, again, a very common spot there, precipitated by dorsiflexion. History of ankle sprains is common. Location also is very discrete, so it's very specific. And this is one of those types where you want to ask the athlete, is it radiating, is it diffuse pain, or can you give them a pencil, the point of a pencil, and say, point to me where the spot is. And they usually can do that. They'll say, just like with plantar fasciitis or a heel spur, You've heard that it feels like I'm walking on a thumbtack, and it's very precise, very specific point. They'll say the same thing about anterior ankle impingement syndrome. It's right here. It's not here, it's here. Not here, but here. And they're very discrete, it's very specific. So if they can do that, that should also be just a little flag that goes off in your mind of, all right, let's think about what this could be here. And then the other one here, the manual compression of the lateral aspect of the ankle recreates the symptoms. Okay, so you can actually you can just flex it up and put a little pressure on it, almost like a Taylor tilt test with dorsiflexion, and okay, that hurts, because they feel that little pin poking them right there. So, and here's again what that looks like on an X-ray, and you can see the little bone spur, little ossification there. Again, this is just from kicking a football, okay, 100 times in a practice over the course of several years. You know, and this builds up. You've seen the punters practice. They go over to the side and they just take a bag of balls and they just kick up and down all day long, just up and down the sidelines, kicking the ball, and that's exactly what this is. Okay, so we've got to be mindful of some of these things. So, all right, so let's talk about the anterior impingement syndrome and its relationship to a high ankle sprain, because this is interesting, and you'll see here on the graphic that I have there. I can't really use my little, but right here, okay, is the anterior inferior tibiofibular ligament, and that's one of the most distal portion of that is typically what's damaged with a high ankle sprain. What happens is that gets damaged. It sits right over the synovial joint there, the synovial membrane, and that trauma actually thickens that ligament and thickens the synovial joint. And most of the time, you actually, I shouldn't say most of the time, but a good amount of the time, you will have ankle impingement syndrome without that osseous, without that bony formation, okay, without that osteophyte. And you'll get just the thickening of the ligament, like that first X-ray or that first MRI I showed you. And that thickening of the ligament and that thickening of the synovial membrane actually is what gets pinched in between the talus and the tibia, causing the problem. So again, this is secondary to high ankle sprain. So if you have an athlete who has experienced a high ankle sprain, they are predisposed to this type of injury. They may not develop an osteophyte, but they are predisposed to the impingement syndrome, where they'll tell you they've got kind of that soft plantar or dorsiflexion. They really can't get all the way to where they want, and it gets a little painful at the top when they dorsiflex it up. And they can't push off if they're running to push in the extreme dorsiflexion. If they're doing deep squats, they're just like, it kind of hurts my ankle. This is probably what it is, and we need to look at that. So imaging studies are general. Now, what's interesting about this, and I can summarize the slide for you, I won't read the slide to you, but imaging studies have been done, and one of the interesting things about the imaging studies is it's also missed a lot in the imaging studies, not because the images don't show it, but because you're not looking for it specifically. So when you refer an athlete for an image, whether it's a CAT scan, a CT scan, MRI, whatever it might be, make sure you tell whoever's reading the x-rays to look for it specifically, because they typically miss it because it's not looked for specifically, not because it's not obvious there. Because it's, quite honestly, it's just one of these things we just don't think about a lot. So it usually is seen in an axial view, so you got to have a specific view, especially if it's non-osseous. Now, if it's osseous, then the x-ray will show you like I showed you a minute ago, but if it's non-osseous form, you're going to have an axial view for an MRI. The physical exam. So what are we looking for when the athlete does present and they do show up with this? So obviously we're always going to do a comprehensive exam, so we're not worrying about that. But we want to look for alignment issues, okay, particularly that subtalar joint that I mentioned a moment ago. A lot of times, remember, the athletes are asymptomatic. So they're saying they're fine, they're competing, they're active. They're just like, hey, doc, it just hurts a little bit. You know, it's just kind of this, it kind of aggravates me, but I can generally still do everything I want to do. And that therein lies the problem, because the athlete is doing everything they want to do. They're compensating for it, and they're telling you, oh, it's a little sore, it's a little tender. It hurts when I flex all the way to the top or point my toe all the way to the bottom. But other than that, I can still function and perform relatively well. So this is why, again, you're going to make a specific effort to look for abnormal alignment. And in this case, we're talking about the subtalar joint. Okay? Joint effusion. Where is the swelling? Is there swelling in the joint capsule right there? Can you see the tendons and ligaments of the foot like you normally can? Or is there just a general swelling there that kind of makes it hard to differentiate? And then is there soft tissue edema as well? Achilles tendon, for example, anterior tibialis, for example, runs right across the front there in the anterior portion as well. That can be aggravated. So you're looking specifically for these. And then you're also going to obviously systematically palpate for localized tenderness. And again, it goes back to, especially on the anterior portion, you want them to find right here, not here, not here, but here. And you want that very specific local tender spots. You want to palpate for that. While anterior lateral tenderness is characteristic in impingement syndrome, posterior impingement signs are much more difficult to elicit, again, because of the deeper structures that are associated there. Passive and active range of motion of the joints should be measured bilaterally. Okay, this is where it's important. I should maybe highlight that one because, again, remember the athlete is coming in and they can usually do what they want to do. So you ask them to do active, they can get up here, but it hurts, and I can get up with this one, and that's fine, and it doesn't hurt. You want to note that, so you're doing passive and active together, and it's important for you to do passive because you want to take them and you want to measure with your goniometer here. This is where you want to know if there's 1 or 2 degrees difference, okay, because there might be, and that might be all you really see, but there will be a little bit of a difference. So you want to make sure you're using your goniometer to measure these in particular. You want to make sure you examine the perineal tendon. Again, that's one of the common misdiagnosed things. You want to make sure it's not perineal tendonitis. You want to make sure it's not Achilles tendonitis. And then you're going to check for deformity and subluxation, and then the sural nerve is usually involved. Okay, so you want to make sure that there's no hypersensitivity there. Okay, or I'm sorry, let me correct what I just said. It is usually not involved, so if there is a sural activity, numbness, tingling, you want to make sure you note that because it shouldn't be happening. And then I showed a little picture there of, in case you remember how to evaluate the myotomes and the dermatomes of the sural nerve. Okay, that's for posterior impingement syndrome. So if we look here, we'll also see for a posterior side, you've got that Achilles tendon is assessed for fusiform enlargement. Okay, and there's a picture of what fusiform enlargement looks like. It's narrow on the top, narrow on the bottom, and thick in the middle. Okay, it's got that. That's a fusiform enlargement. You want to look for retrocalcaneal bursitis because, hopefully that's what it is actually and not posterior impingement syndrome. You want to look for medial and tibial nerve. You want to make sure you do an anterior drawer test and a Taylor tilt test to exclude ankle instability. And then you also want to do a straight leg raise, and it can be seated or supine to exclude radiculopathy of S1 and L5. And these are typically how we will do a thorough exam. And then, of course, all your other stuff that you are going to do. These are the things you want to add to that exam. And then the treatment for it. And as we're winding down here, but there's 7 treatments that the literature suggests. So these aren't necessarily my ideas as much as I just took this list from the literature that's out there and exactly how it's been treated by different physicians, physical therapists, and athletic trainers over the years. So the good news is non-operative treatments are very helpful. Okay, they're very productive with this. So one of the things you'll do right away is a heel lift. Heel lift can help. And we're not talking, you want as minimal a heel lift as possible. So you start with a certain thickness and work yourself down to the smallest possible elevation that you can. You also want to modify activity. And I gave you that list a minute ago, the orange slide. And Natalie has these slides, so you can look these up again. But modify the activities. Most of the time, this helps. Instead of doing a deep squat, just go parallel, for example. That you can still get plenty of the workout, everything every coach needs and are happy with if they're going to parallel. Just avoid the super deep squat, for example. Okay, so you can modify the activities. You can tape or brace, which is again very effective because a lot of times all I need to do is put enough support around the ankle to limit or to modify a couple degrees of motion. So most of the time, with just the tape jobs we apply to our athletes, we can modify that. So we want to make sure we're looking for those. So those are very good treatments. So I have a few more here. Joint mobilizations are also very productive. in treating this. And matter of fact, there's a case study in the Athletic Training and Athletic Therapy Today journal about specifically using joint mobs for this condition, for anterior ankle instability. And the Mulliken technique is just a name of a particular technique where you stabilize and do an anterior glide with posterior force simultaneously. So you're basically just doing a drawer test is the joint mob there. So you want to do joint mobilizations. Obviously, NSAIDs will help with the inflammation. Dry needling has been recommended and tried in the literature. And I know that's a big topic these days for a lot of athletic trainers, but it's been shown to be helpful with ankle impingement syndrome. And then the gold standard is the corticosteroid injection, and that's typically where the physicians will go to first. It also is other than surgical examination, opening up and looking at it, the best way to diagnose it is cortical injection. They inject it, it goes away. Typically, it's ankle impingement syndrome. So it's therapeutic as well as diagnostic, the injection. So that helps quite a bit. In most of the literature that I have read, the injection is the treatment of choice. And then, so that's non-operative treatments. And then for operative treatments, and I should say the injection is the non-operative treatment of choice. The most effective is arthroscopic, surgery. Go in there and clean it out. It's again, that's the gold standard. It's pretty good. We don't typically want to do that. We don't need to do that. The non-operative treatments are very effective. But if it's problematic, the patient maybe is a little bit older, they can't quite do the things that they want to do, it's easy to go in and just clean out the scar tissue or take away the osteophyte. And again, usually it's a 6 to 8 week period, and they're back to full go. And the interesting thing about it, I think I have it on one of these slides coming up, is on the surgical studies that I've read, over I think it was 976 surgical. They did a meta-analysis. They looked at 19 different studies of surgical intervention. Of the 19 different studies, that equated to 976 total patients. They went through the study. Between 76 to 100% of the patients were completely resolved and completely satisfied with the treatment. So that's why they say it's the surgical intervention is the best way to go, because when it's done, up to 100%, almost 80 to 100% of patients are completely satisfied and have no recurring issues at all post-op, up for several years. So it's a good outcome. Obviously, there are surgical complications. Fortunately, with this, it's very low complication. The complication rate, again, that same meta-analysis that I just referenced, is 5%. So you have a complication rate of 5%. So it's very small, and the complications are due to just the surgical technique involved and not necessarily the condition. So you can see those are common complications to all surgical interventions. So just kind of in summary here, got a punter there practicing. You can see that doing that all day long can cause some problems there. But anyways, ankle impingement syndromes have been increasingly recognized as a cause of chronic ankle pain, especially in younger and athletic age groups. Okay, this is huge, and these are studies from 2015 on up. So we're seeing it's becoming much more common in these athletes. And part of that is, it's not that it's recurring more often than it ever has before. There's two reasons. Is one, the athletes today are just starting at higher intensities much sooner. So because of that, their frequency and intensity is much sooner, much younger. So they're starting to have accumulated stresses by the time they become a sophomore in high school, for example. That's one reason. The other reason is we're just much better at our jobs. And because we now can differentiate, again, 30 years ago, 20 years ago, we weren't differentiating between peroneal tendinopathy, Achilles tendinitis, retrocalcaneal bursitis. We weren't doing those kinds of evaluations or interventions, and now we are. So we're becoming more specific in our diagnosis. So because of that, we're starting to recognize that it's more common than maybe we have thought. Again, up to 13, 14% of our athletes may be having these. It's a consequence of an acute trauma or insidious onset. So that is, again, one of those unique factors there. An athlete can come in having just had a high ankle sprain and they're predisposed to it, or they never had an injury and they just kick a football 100 times a day for the past 3 years, and that could also be a contributing factor. So that, in my opinion, is a huge part of our evaluation we need to consider. The precipitating mechanism of injury implies concomitant ankle abnormalities, which usually means you have ankle impingement syndrome and something else. Okay, and this contributes to that reason why it's misdiagnosed or mistreated, because we treat the one but not the other. We'll treat the ankle sprain and we don't do the dry needling for maybe what else could be there. So we want to make sure we diagnose all the injuries there, not just quit when we find one. We got to make sure that there's not something else. And this AIS is that something else. And I guess if I could leave you with any other big point today, it would be that. We evaluate ankles all the time. We do it in our sleep. I mean, it's automatic. We deal. This is just part of our identity as athletic trainers. So we feel like we're really good at this, and we are really good at this. But AIS is one of these things where it's secondary or in addition to or concomitant with these other injuries. We want to make sure we find the ATF sprain, the calcaneal, whatever sprain it is, and rule out AIS. And then finally, imaging should be performed, again, as a good way to help diagnose it. Keeping in mind, you want to ask your physician or the radiologist to look for it specifically. And again, it does coexist with other abnormalities. So there you have it. Ankle impingement syndrome. There's my email, my Twitter, and happy to entertain a few questions. I think I have a few minutes.
Hey, we do have a question. Doctors use injections to dissolve heel spurs. Could they use this injection method to dissolve the excess bone instead of surgery?
They could. Yes. Yes. No other explanation needed. Yeah, you would treat it the same way for a heel spur.
Any other questions? No? Thank you.
All right. Oh, we have one. Don't clap yet. We have another question. Yes. Yes. Because it adjusts the alignment of the foot dramatically. So we talk about the subtalar joint and navicular. If we've got extra structures in there, even a fractured navicular or drop navicular, those all contribute. Because again, this is about the athlete adjusting his or her mechanics, their foot mechanics, to accommodate some sort of blockage. And this is the other part about this particular injury, is there's so many contributing factors, and it's just the malalignment, the repetitive trauma, as well as the acute piece. So yes, it definitely would be a contributing factor to consider. Great question. Now you can clap. Thank you.